Hello, everyone. I'm Patricia Davidson. I'm the Vice Chancellor and President of the University of Wollongong in Australia. And it's my great pleasure to be a speaker moderator today in this session, where we're going to address the tsunami of non-communicable diseases. Over the last few years, we've heard a lot about COVID-19, but also the risk factors associated with non-communicable diseases. And the fact that maybe, from my perspective, sometimes this binary division between communicable and non-communicable diseases is theoretical, but in real terms, as people live with chronic diseases such as HIV, tuberculosis, and non-communicable diseases such as hypertension and cardiovascular disease, we have to really be agile within the healthcare systems to react to these challenges. So to help us today address this complex conversation and issue, we have a really dynamic global panel. I'm speaking to you from Sydney, Australia, and we will have people from all around the world. So please let me introduce you to my colleagues. Abigail Kazembe, who's Associate Professor of Midwifery at Kamuzu College of Nursing, Malawi, and also President of AfriHealth. And I'm really proud to say an alumni of the University of Wollongong in Australia. Welcome also to Laura Magaña, President and CEO of the Association of Schools of Public Health, who's speaking to us from beautiful Washington with the blossoms in the background. Adnan Hyder, who is the Senior Associate Dean of Research at George Washington University. Agnes Soucat, Head of the Division of Health and Social Protection in the French Development Agency in France. So as you can see, we have a global panel, and we have the opportunity for lots of discussion and debate. How we thought would be best for this panel is that we are going to hear from each of our speakers, who are going to present a discrete element of this complex discussion of non-communicable diseases. And so each of our presenters is going to present for about 10 minutes, and then we are going to come together for a discussion. Please add your questions to the Q&A function in Zoom or the chat, and I'll do my very best to be able to put some of those questions to our panel members, and also to summarize the reflections that people have over this session. So without further ado, I'm going to start off with Laura Magaña, who's going to speak to us on really some of the important issues in addressing public health, particularly from a high-income country perspective and from her lens of looking at the activities of all the schools of public health in the United States. So thank you so much, Laura.
Thank you so much for the introduction. Very kind, and thank you for inviting me to this session. And I'm just looking forward to learning from all the panelists and, of course, all the audience that are here with us today. So I'm going to start with that view and with some reflections, and hopefully just to get a discussion at the end. But the pandemic has exposed what those of us in public health have known for years. Many national and global health systems are not prepared to address the current tsunami of non-communicable disease, neither new and emerging public health crises. While most attention has given to low and middle income countries, and certainly a lot of focus needs to be put there, those of us in high income countries must also concede that we also have a lot of work to do. Health systems around the world fail to provide equal access to all populations, and huge disparities in access and health outcomes exist in high-income countries as well. NCDs result from fundamental inequities in social and economic determinants of health, in access to timely, high-quality services, in health information, in living environments, and in many other social factors. We tend to think that the disparities are among the countries, like high-income countries, medium-income countries, low-income countries, but the inequities within the high-income countries are enormous. And there's a great challenge to the health system in these countries. So this is a metro station from Washington, D.C., where I lived. And the difference in life expectancy, just to talk about one health outcome, from downtown D.C. to 7 metro stations to Montgomery, which is maybe around 20 minutes, is 7 years of differences. So COVID-19 has highlighted long-standing inequities in the health system, of course, in the high-income countries. Just an example, in US, compared with white people, minorities, in particular Hispanics, Blacks, and Indigenous people, have experienced more than 1.5 times the case rate, 3 times the hospitalization rate, and 2 times the death rate. Since health inequities is still a relatively new field of health research, it faces research and practical application challenges that must be addressed to share knowledge and advance the coverage and effectiveness of health systems. Thus, to fully understand health disparity, the use and collection of accurate and updated data, health indicators regarding social determinants of health is needed to understand and eradicate health disparity while improving health community interventions in high-income countries. Strengthening the health system also requires a greater focus on solidarity and redistribution in social protection systems to address underlying structural inequalities, racism, and poverty. Despite much talk of the importance of health promotion, even across the richer OECD countries, barely 3% of the total health spending is devoted to prevention. So very briefly, I just want to list some of the interventions that WHO in the European region has actually, it's like a pathway with interventions really to improve. All of these are evidence-based, are high impact, cost-effective, affordable, and feasible interventions to implement in a variety of health systems, really to advance our approach to NCDs. Number one, in terms of governing for better NDC outcomes. So really, the point is to strengthen governance arrangements that can ensure coherent policy frameworks and sustainable intersectoral action for NCDs, connecting national, regional, and local levels to align multi-layered policies and accountability frameworks, focus on improving key outcomes and reducing inequalities. Number two, to strengthen public health services to tackle NCDs. Well-resourced public health services can spearhead the health system response to NCDs by providing policy-relevant information on the disease burden, putting the spotlight on equity dimensions. Number three, transforming individual health services towards integrated multidisciplinary primary health care. There are underexploited opportunities to move towards larger multi-profile primary health care teams to support early detection and management of conditions in the context of multimorbidity. Multidisciplinary teams can proactively manage community health and well-being. Number four, transforming individual health services, regionalization of specialized care for NCDs. Adequately regionalized specialist services can provide efficient and timely care for acute conditions. This is critical, not only to improve response to acute events, but also for health system efficiency. Regionalization requires service re-engineering in a manner that is nuanced, flexible, evidence-informed, and people-centered. Number five, a people-centered approach to strengthening health systems for NCDs. People-centered, instead of provider-centered care, is critical not only for the health system's responsiveness, but also for better NCD outcomes. Patients and their caregivers can be considered as the frontline workers for NCDs as they make everyday judgments and decisions about health promotion, disease prevention, and care to maintain and improve their quality of life. Number six, NCDs and human resources for health, a workforce fit for purpose. A health workforce fit for purpose in terms of skills, composition, roles, and responsibilities, and numbers is fundamental for transforming health services. Number seven, health financing strategies to support scale up of core NCD interventions and services. Adequate and prioritized health financing arrangements can be powerful enablers of transformation in public health and in primary and specialized care, scaling up NCD interventions and services. Number 8, medicines, a multi-pronged approach for a complex problem. Long-term and equitable access to affordable, quality, assured, safe, and effective medicines is essential to achieve better NCD outcomes and improve the financial protection. And number 9, health systems information solution for NCDs. From clinical consultations to macro-level resource allocation, health system information solutions can contribute to long-term benefits and equity of care, quality continuation, coordination, better planning and resource allocation, efficiency gains, and enhanced evidence-informed health services delivery and policy maker. So all of that we're going to be talking about, I think, in the next interventions, but it's just a touch of the kind of intervention we should be all talking about, regardless of the country we are in. And just to touch finally in 2 other reports, which are actually stress importance of this one, stress importance of the workforce, according to the 22 McKinsey report in building the public health workforce of the future. There are 6 strategies for building and strengthening the public health workforce for the future in high-income countries like the United States, but also around the world. Number 1 is reassess capabilities and roles. Invest in a systemic exercise to identify competencies needed for the future. Assess current competencies and staffing levels, and create tailored role-specific workforce expansion plans. Number 2, share resources and engage partners. Leverage momentum gained through partnerships to redefine state-local collaboration and the role of external partners. Number 3, overhaul the recruitment process. Build innovative recruitment platforms that streamline processes, broaden talent and pipelines, and increase accessibility to combat the Great Resignation. Number 4, invest in employees. Ensure that the workforce feels well supported with clear paths for development and advancement, especially given the extreme burnout experience during the pandemic. Number 5, cultivate strong leaders. Recreate the ranks of public health leadership through internal upskilling and external recruitment, especially given the exodus of public health leaders. And number 6, promote diversity, equity, and inclusion. Prioritize health equity to ensure that the workforce reflects the community being served. Potential initiatives can include creative recruitment efforts, refresh job classifications, and trainings focused on diversity, equity, and inclusion. For the third and last report, which is the 3D Rockefeller Commission, published its report a few months ago with 6 principles to strengthen health systems that really connects and emphasizes the importance of data in social determinants for the decision-making process. And they talk about these 6 principles, evidence-informed decision-making to promote healthy societies that needs to improve data systems and data analysis. Number 2, like all decisions about investments in any sector need to be made with health as a consideration. Number 3, the decision-making that affects the health of populations needs to embrace health equity, while also acknowledging potential trade-offs between short and long-term costs and benefits. Number 4, disaggregated data on the determinants of health should be used to inform decision-making about health. Number 5, health systems should contribute to better, more transparent, and more accountable governance and health outcomes. And 6, if health systems need to promote health societies, then it needs to be participatory and inclusive of multiple and diverse perspectives in everything they do. In conclusion, our health systems around the world, regardless if it's a high or low or middle income country, they need our immediate attention if we are to protect the health and promote well-being of everyone everywhere. So we need to seize the moment and the visibility of the pandemic brought to public health to innovate and strengthen the health systems around the world. If we don't do it, who's going to do it? If it is not now, then when? Thank you.
Thanks so much, Laura, for setting up this conversation so well and introducing our current situation and some challenges ahead. and also some opportunities. Now we're going to move to Abigail, who's going to provide her perspective, particularly from AfriHealth. Abigail?
Hello.
Hello, Abigail. Yes, we can hear. And thanks to everyone who's joined the session. Abigail's internet connection is not so strong, so please let's bear with Abigail. Abigail, over to you.
Thank you. Can you hear me?
Yes, we can hear you.
Okay, thank you so much. I'll pick on what Lola has said, but reflecting on low and middle income countries. I know we have a speaker who is going to show us the magnitude of NCDs, but I just want to mention a few things as a starting point. We all know that NCDs are a leading cause of mortality, killing up to 41 million every year, which is equivalent to 71% of all deaths globally. But if you look at these figures, 77% of all deaths are in low and middle income countries. And we have been living for the past few years focusing on other diseases, but neglecting NCDs or not paying much attention to NCDs. And now that we know that it's killing a lot of people, we have the evidence, we have the data, it's time that we start doing something about it in a big way, because people with NCDs have been heavily affected by COVID-19. We all know that. And the population of even young people who have the potential to develop NCDs is increasing, because now we live in a global village and we are exchanging food, lifestyles. We watch how other people live in the other part of the world. So we are also equally affected with non-communicable diseases. And I think that is a threat, and that has posed a big threat to our public health systems. I just wanted to talk a little bit about our systems in terms of service delivery. I think Lola alluded to the fact that the services have to be accessible, equitable, person-centered, but what do we have now? Our system is suffocating because we have increased numbers of patients with non-communicable diseases, but not all of them are accessing the services because they are so far apart, or even where they are, you find that most of the resources that support care of patients with non-communicable diseases is scanty. So we do have a problem in that respect. The other problem, which really makes the situation worse, is we really have to find out, where does our population live? Is it in the rural or urban? And where are our most services targeting? And who are they targeting? Another challenge is that we have limited number of health workforce. And most of the times when we do our recruitment, when we calculate our numbers or our requirements, sometimes we don't do a proper analysis and also specification to find out who is needed where and for what reason and for what purpose, and what is it that they are going to do well in that place. So we need to tailor even our training based on the needs of our population, and also deploy them where they are best needed. They are needed most. And there is issue of decision making, making use of the health information that we collect, and use the data to make decisions I think the environment in which we operate is so complex. We have a lot of stakeholders that also influence the decisions that we can make. We have challenges with the finances because our budgets are not adequate to address all the challenges that we experience on a daily basis. And also, when we have the resources, sometimes we do experience challenges also to manage those resources. And to some extent, some facilities still experience, or some countries still experience challenges with the leadership and governance. So those are some of the challenges that as low-income countries, we are facing to manage our public health systems. Now, let me pick a few things that AfriHealth as an interprofessional association is doing. AfriHealth is a follow-up of an association which was born after Medical Education Partnership Initiative, MEPI, and Nursing Education Partnership Initiative, which came after, which was addressing the human resource crisis that arose as a result of HIV and AIDS. So the program was implemented for a good 5 years, but then there were some gains that we felt could be nurtured in order to improve our public health systems. So at AfriHealth, we are encouraging, it's an interdisciplinary health professional grouping, and we are making efforts to work with the ministries of health, training institutions, and other stakeholders to improve the quality of healthcare through research, education, and capacity building. I think Laura said it well, that if we have partners on the ground, we have to work with them on how to use what we have, and also how they can come in to help us. I think many of the times we get resources or support, and when you do resource mapping, you see that a country may have a lot of resources, or a particular area may have a lot of resources, but how much say does the health department have over that resource? That's a question that we can put. And sometimes we get partners who come with their agenda, and we are trying to meet and discuss and zero in on the issues. Sometimes you find that there are challenges in quite agreeing on how we can manage the resources that are there. In terms of training, we have issues with the human resources. And as an association, we are working with the training institutions within the globe. We know Africa is multilingual, so we try to be inclusive in terms of French speaking, English speaking, of course, and Lusophone. We may not have penetrated quite far in the other regions because we are a new association coming up. But the idea is to make sure that we understand what our problems are and what solutions can we offer. So we are doing interprofessional research in various areas. Even in training, we are testing out models of interprofessional training using either pre-service or people who have just graduated in order to address some of the challenges. But I think the training that we need to conduct, especially pre-service, is also to assess what are the real needs of our population. How can we respond to these needs of the population? I can just give an example of the recent pandemic, COVID-19. Many are the times that you have a team of health workers, but for us to really understand each other, and to appreciate each other and address the problem and participate in the decision-making of patients, sometimes it becomes a challenge. So at AfriHealth, we are trying to use an interprofessional approach to training so that we can understand each other's profession and we can know what the limitations of each profession is. And in the long run, if you look at it, even issues of quality of care can improve because you are not just looking at the ear or the heart or the leg or the pregnancy. Rather, you want to look at the person holistically. And you can do that by working together. All these people that are concerned in the care of this particular patient can work together and provide that person-centered care that is required. And also, if you do that in the midst of human resource crisis, it means we have saved on a duplication of efforts. If a nurse goes there to ask to take history, a physician will go the same direction to take history. Of course, maybe it may vary, but there are certain things which are so common. So we are also trying to teach each other so that we don't work in silos anymore, because there's time wastage of resources, and also people get frustrated, and even the patient may not be satisfied with the care that they receive. So I think that's an important issue about service delivery. In terms of medicines and technology, we have just learned from the current pandemic. Our colleagues in the north, tried hard to develop vaccines and vaccinate people. I think as a continent, it's also time that we need to explore the technologies that are there. It may not be manufacturing a vaccine per se, but it may be a simple technology that is already there, but that can save some lives. So this is what AfriHealth is trying to do: know our problems, know the solution, use the available knowledge that we have to address some of the challenges that we have. So in terms of strengthening our health systems, it's something that we need to join hands. We have issues with the capacity building. How do we strengthen our capacity? We have issues to do with accountability and responsibility. How do we do that? We are hoping that we are working together with the ministries of health, where public health systems are a home to, and we are hoping that by working with the key people in these systems, it is one way of strengthening our systems. In terms of finances, yes, we get supported. We have our own little budgets. I think it's time also that we start examining the services that we provide and see which ones, how best can we mobilize finances. Sometimes we want to overcharge and deny people access, but is there something that we can do? We know that through research, we can explore some of these mechanisms and find out how best we can utilize the resources that we get, and also how best can we mobilize the resources that we already have. We believe that if we want to go far at AfriHealth, we must work as a team. That's our belief. And with these few words, I want to stop there. Thank you.
Thanks so much, Abigail, for casting the spotlight on some unique issues in low and middle income countries, and also profiling the excellent role that AfriHealth is playing in terms of forging a interprofessional agenda. I've just, for people who have joined the panel, I've just popped the link to AfriHealth in the chat. And also just to want to put on people's agenda that there is the 5th annual symposium is from the 2nd to 4th of August this year. So thanks so much for providing us with that overview, Abigail, and I'm so glad that the internet stayed strong. Now I'm going to hand over to Agnes Soucat from France, who's going to give us more of an economic and finance perspective on NCDs.
Thank you very much. Very happy to be here at CUGH again. Are you seeing my presentation?
Yes.
Sorry, yes,
Yeah.
please. Sorry. And if you could go on to screen show, please, Agnes.
Yes, I'm going to do that.
Thank you.
So very good to talk to you today. And what I'm trying to do in bringing to your attention the health financing story is to look at what we have learned over the past 20 years on how countries go about health financing and what are the trends both in high income countries and in developing countries, and what has happened during 2020 following the COVID-19 crisis. And my question today, when we look at what has happened over the past 2 years, is whether when it comes to health financing, we also have entered the world of tomorrow. And I'll come back to that as what we can see of the signs that this is the case. So how much globally was spent on health in 2019? Global spending on health represents about 10% of global GDP today. So that's 10% of the global economy, about 8.5 trillion in 2019. I'm presenting the 2019 data because health expenditure data are quite complex to collect. They're part of national accounts, and they are national health accounts. And in developing countries, we usually get them at about 2 years after they've been incurred. In some countries, some high income countries, we manage to have them 1 year after, but it actually takes time to consolidate spending. As you know, expenditures don't always correspond to budgets, and budget and expenditure consolidation takes several months. Within this spending, this global spending on health, about 60% comes from government sources. And you see that little white dot here at the bottom, that's actually external financing. And whereas global spending on health is counted in trillions, external financing is counted in billions. So it's really a drop in the ocean of spending on health, the 17 billion in 2019. So where is the money? Actually, and it may come to some surprise. In fact, most of the spending on health happens in high-income countries. And it's actually more than 80%. It's about 80% that is spent on in high-income countries. And half of it, a little bit more than half, actually 42% of total spending is actually spent in the United States. So the United States spends close to 19% of GDP. That's a fifth of the US economy, which is the largest economy in the world, that is spent on health. And you see at the bottom, the little line that is actually getting smaller over time is the spending in low-income countries. The spending in low-income countries has actually not increased while over the past 20 years, while it has increased quite significantly in high-income countries and in emerging economies. What is it spent on? Well, mostly, as you know, it is spent on non-communicable disease. And if we look at the spending on non-communicable disease in low and middle income countries, we also find that there are significant amounts that are spent on NCDs. Of course, the categorization is difficult to do, and I agree with the previous statement that it's clearer and clearer that the categorization between infectious disease and non-communicable disease becomes increasingly irrelevant in light of emerging science on the role of infectious agents in NCDs and the role of NCDs in triggering seriousness of infectious disease, as we've seen during COVID-19. But the fact is, there is a general sense sometimes that developing countries spend most of their resources on health, on infectious disease or reproductive health, but they do spend at least a quarter of their spending on non-communicable disease, and it is probably largely growing. In fact, domestic funding in these countries is largely spent on non-communicable disease, as you can see, that are the green dots, while it is external aid that is mostly funding infectious and parasitic diseases and also reproductive health. You see on the right, in the blue dots, external aid, mostly 70% of it goes to infectious disease. But governments spend actually more on NCDs. So although low-income countries and low-middle-income countries spend less on NCDs than high-income countries, they spend substantive amounts, and these amounts are actually increasing. If we look at primary health care and what is funding primary health care, when we look at the recommendations of increasingly preventing and treating NCDs at first level of care, again, while in richer countries, primary health care is mostly funded through government. You see here in upper middle income countries, it's about 50% of primary care spending that is funded by government in upper middle income countries. That's not the case as the countries are poorer. In low income countries, the majority of primary healthcare spending is actually funded by household themselves. It is out of pocket, and there is a significant role of external aid in funding this primary healthcare, while domestic funding of low-income countries is very little used for primary healthcare. If we look at how this spending has evolved over time, again, what we see is that economic growth is the main driver of health spending. It is not the priority that governments give to health, but it is the economy and the growth of that economy. And if you look at the data on health spending over the last 20 years, you'll see very clearly that high-income countries have increased their health spending as a share of GDP. So societies give increasing priorities to health, largely driven by treatments of NCDs. And you can see that upper middle income countries just follow suit. But when we look at lower middle income countries and low income countries, we don't quite see the same trend. And more worryingly, over the past 15 years, we tend to see either a stabilization or even a decrease in health spending in these low income countries. So while you can see that in high income countries, you have health being funded largely through government transfer to public spending. So in high income countries, it's 48% of direct funding from taxation and 20% from social health insurance contribution. You see that you have something that is close to that in upper middle income countries. But you see again, as you go to lower middle income countries, there you have an increasing share of household contributing to health, yet you still have a dominance of public spending and support from aid for lower middle income countries. But there is one exception, and this is something that is quite worrying as COVID-19 has hit the world, is that over the past 20 years, low-income countries continue to heavily rely on out-of-pocket spending and on aid. And aid has increased over the past 20 years in those countries. The share of health funded by aid has increased, but it has been at the expense of public domestic spending, which has generally decreased. So external aid has been offset by declines in government prioritization of health in some aid-dependent countries. You see it here very clearly. The low-income countries at the bottom, this is public spending, government spending on health, has been decreasing in low-income countries. That's the red line, and has been just stable in lower middle-income countries. So yes, public spending is increasing. It is increasing following economic growth and taxation and formation of collective public financing of health, but it is not happening in low-income countries. What we have in low-income countries is actually a strong substitution effect that is a decline. You see on the curve, a decline of domestic public funding as aid in green and yellow has been increasing. When we look at what has happened in 2020, then we see that generally health spending has increased, but it's because total public spending, total government expenditures has increased, but total government expenditures has mostly gone into either social protection or counter-cyclical support to businesses and compensation for unemployment. But in fact, health spending has been declining as part of total government expenditures in about 2/3 of the countries that were analyzed, mostly high-income countries. And what we see is out-of-pocket spending has declined as a share of spending on health, but it has increased as a share of household spending, which means households during the crisis have become poorer, and their health spending has actually increased as part of their overall budget. So in summary, what we know is that over the past 20 years, health expenditures have grown faster than GDP overall globally, with public spending playing a large role. Yet in low and some low middle income countries, aid is substantial, and health priorities in government spending fell in line with increased aid. Overall, out-of-pocket spending, that's how much people spend from their own budget, own household budget, has risen across all income groups on a per capita basis. So generally, the world spends more and more on health, both from private sources and public sources. But public sources are growing faster, and it's mostly because of high-income countries and emerging economies who spend more and more money on healthcare, mostly for non-communicable disease, but recently also to respond to the COVID-19 crisis. So a major increase in public spending. that external aid that is still supporting low-income countries largely goes to preventive care, to PHC, and to infectious disease. That's about 70%. But governments of poor countries already spend significant amounts, more than 25% of their spending, on NCDs, and domestic public funding generally has been decreasing in low-income countries. And I will finish by saying that still this use of the NCDs and non-NCDs categories proves increasingly difficult in analyzing health expenditures, and probably we should start thinking about different ways of analyzing the data to better understand the impact of behaviors, food systems, and the role of risk factors on public and private spending on health. Thank you very much.
Well, thank you, Agnes, for that truly exceptional talk and summary of the issues that we face. And like you, I feel that we're sort of entering a new epidemiological transition where we have to refine our nomenclature, which is going to drive us forward. But it's kind of, I think this is a deep conversation that we might come back to, particularly, you know, in terms of how we train health professionals, the professional societies, the donors. So much food for thought, truly exceptional. Thank you, Agnes. And now we're going to move to Adnan Hyder, who's going to take us to more of a policy lens, and then we're going to take a deep dive into many of the issues that have emerged. So over to you, Adnan.
Thank you very much, Trish. Just want to first confirm that my slides are visible. Do you see them?
Yes.
Okay, fantastic. Well, thank you very much. First of all, to the Consortium of Universities for Global Health for inviting us, and particularly for hosting this plenary session on non-communicable diseases. What I'm going to do for my slot is really express what I might say you've actually heard a little bit in the previous three presenters, although we did not maybe coordinate that, a series of discontent. And what I want to do is to take that feeling that we aren't exactly doing what we may be required by the world to do, and pose that as a series of 4 questions. So I'm going to pose 4 questions during my talk and provide a little bit of evidence behind why I'm actually posing those questions. I am conscious of the fact that I want to right at the forefront say that I deeply value the work of governments, institutions, and individuals in the field of non-communicable diseases, particularly over the past 20 years. But I do think that for a true dialogue, we must be introspective, we must question the value of our own efforts, and continuously strive to assess whether indeed we are fulfilling the needs of the health of the people around the world. So let me begin by asking the first question, which is our current status and state of NCDs, policies, and interventions truly satisfactory? And as a reminder, I wanted to remind people that less than 10 years ago, the world decided on voluntary targets. These targets were quite comprehensive. They covered behaviors, they covered risk factors, they covered diseases for non-communicable diseases, or NCDs, as I'm going to refer them to. They were very reasonable. They were good goals to try and achieve over the coming span in the early 2000s. And more importantly, the Sustainable Development Goals included not only general targets and indicators for health, but very specifically speaking for NCDs. And not only was there a specific target for NCDs, but they were allied health targets that covered things like alcohol and tobacco and medicines and universal health coverage, all critical for the achievement of a world without NCDs. And yet, when we begin to think about what have we done in this past 10 years or so, approximately, from the times of these discussions, the World Health Organization is alerting us that very, very few countries are actually on target to meet the SDG goals. In fact, not only are a very few number of countries on target, but the pace of change has rapidly declined. So the positive improvements that happened in the earlier part between 2000 and 2010 have actually declined that pace after 2010. This is of serious concern. It's a little bit consistent with the picture that both Abigail and Agnes presented to you earlier. More importantly, not only is it a question that in fact, NCDs in terms of defining health service delivery packages or universal healthcare packages haven't made as much an impact. In fact, in comparison with infectious diseases, the progress has been slower as well. So not only are there concerns about the absolute change that the world is having in terms of reducing NCDs, but also in terms of the relative impact, something again that my former speakers have also raised. I think what this fundamentally really came to light was in the midterm evaluation of the progress towards NCDs. And what this table simply demonstrates is that out of 194 member states where these repeated surveys are being done to see what is the state of implementation of NCD policies and NCD related interventions, the fact is that over the past years, particularly in this past decade, the progress has not been as rapid, is less than optimal. And in fact, many of these, whether it talks about an overall action plan for controlling and preventing NCDs at a national level, or a specific policy that is pertaining to healthy diets, or research policies, which are absolutely vital to generate the evidence needed for local action, the world is not really doing very well. And that is my concern number one today for all of us, that in fact, not only has there been lack of progress, but actually things that were being done are stalled. And over 100 countries are reporting that things that they were doing, policies and interventions that they were implementing have been disrupted since the start of those services, whether they relate to pulmonary diseases or cardiovascular diseases or diabetes or whatever. These reports are indeed of great concern. And therefore, my question is, I don't think that we are really doing very well at the global level insofar as NCDs policy and interventions are concerned. This is something that we need to pay special attention to. My second question, even though we've had this energy and emphasis on NCDs, are we truly serving the needs of particularly vulnerable people around the world? And to try and address this question, I refer to the work of one of the Landsat commissions on non-communicable diseases and injuries, also called the Landsat Poverty Commission, which had special interest to look at the health of the poorest billion of this world's population. And this is important because I want to frame the NCD agenda not only as a health and development agenda, but as a justice and equity agenda. Abigail referred this earlier in her comments, but I want to emphasize this point because when we visualize the state of the poorest billion, that is not an equal distribution in all countries or all regions of the world. As you can see here, Africa and South Asia are regions with dominant proportions of the poorest billion, which means that it is contingent on us as we begin to think about NCD policies and services that we begin to think about the vulnerable in these regions. In fact, if we look at the global action plans for NCDs and some of the best buys, most of those action plans were concentrated at the level of community and at the level largely of either preventive care or chronic care at health centers. And the notion of primary healthcare was raised earlier. by one of my fellow presenters. But the Landsat Commission suggested that this is not enough, particularly if you're interested in addressing the poorest billion. You have to expand the repository of interventions and policies that you have to higher levels of service, including first-level district hospitals, referral hospitals, but also recognize that there is an important curative agenda as well. And dare I say, a rehabilitative agenda. And in responding to some of the comments on the chat already, a very important mental health agenda as well that is closely related to some of these NCDs. In fact, what is critically important is that we need to be innovative. And the Commission suggested that we need to think about models of integrated care. And this integrated care would happen at different levels of service delivery across low and middle income countries, of course. So my second point is that I'm not sure that the NCD agenda currently defined is really serving the needs of the most vulnerable around the world. My third question. As Agnes has demonstrated, many of these interventions and policies require financing. Many of these interventions have been deemed very cost effective, but there's a tremendous amount of gain if we actually implement these interventions for the people that we care about. If you look at the avoidable years of life lost, the avoidable healthy life, that if appropriate interventions and policies were invested, we could actually avoid, even in the poorest billion population, that number is very, very strong. Which means that if appropriate policies and interventions are actually implemented and reach the people that need it, then ill health, morbidity, disability, and mortality can be prevented. While these analyses are somewhat a modeling exercise for now, we hope that they can actually become real figures over time. And this is what I want to remind all of us, that there are standard things that we need to think about when we talk about policies and interventions. These are not specific to NCDs, but we have to ensure protection against moral hazards. What types of insurance mechanisms or coverage do we have for the poorest of the poor? We have to promote all the positive externalities that come out of these interventions, and how do governments encourage that? We have to protect against negative externalities. And dare I say that governments may not have done an optimal job, for example, for risk factors like tobacco and alcohol and the use of what are termed sin taxes, for example. And then very importantly, an issue that is, I'm sure, near and dear to many people's hearts, which is this information asymmetry, which is the empowerment of people, which is the ability of communities to have a voice in the design of these interventions and programs that they are supposed to be recipients of. That becomes incredibly important. So these four large domains are critical, not only for specifically for all public health interventions, but in this instance, I'm proposing that we may have ignored some of these in the context of NCDs policies and interventions. And so my third point is that we need to do a better job if we are going to get the return on investment that we are calculating on our Excel sheets and in our theoretical models. Ladies and gentlemen, let me wind down by saying that it's not that I don't support the development of global action plans or high-level meetings. I think they're incredibly important. I think public health is inherently political, and we need political support. In fact, if anything, we need to become better at playing the political game. But today, what I'm suggesting to you, and my fourth and final question, is are we truly at a moment where we should just do more of the same, more of what we promised in 2000 or 2010 or 2013 or 2015? Or, if I may suggest, that maybe it's time for some major disruption. Maybe it's time to take on what Laura identified as a new perspective on training, or what Abigail is talking about, ensure that the local voice is heard, or as Agnes told us, maybe the way we are counting things is inappropriate. But something has to change if things on the ground really are going to withhold this tsunami of NCDs. I hope that all of you will join us in a discussion on how can we move in that direction. Thank you very much to to all the colleagues who contributed to my presentation, and my disclosures are provided here as well. Thank you again.
Thank you so much, Adnan, for that very provocative and inspiring talk, which is going to really fuel much of our discussion. So Charles, I might ask you to just bring all of my colleagues forward to be able to start the discussion. But while my colleagues are joining me, I was also, as part of this panel, asked to comment on the healthcare workforce. So I'm going to really follow on a little bit from Adnan's provocation and suggest that we maybe need to conceptualize the healthcare workforce differently. I've really liked a lot of the themes that have come out. Laura talked about the importance of people-centered care and a workforce fit for purpose. Abigail talked about interprofessional care. And I think COVID has also taught us a lot of lessons. And incredibly, many healthcare workers have become patients. And this has been a big lesson to us in high-income countries, whereas in many low-income countries, particularly in the onslaught of HIV/AIDS, that lesson was learned very much. But I just think it's important to recognize that many of the challenges that we talk about in the population directly influence the healthcare workforce. And the healthcare workforce has really been decimated during COVID-19. Firstly, we've seen in some low-income countries where, many physicians have died. It's estimated there's probably 200,000 healthcare professionals that have died across the world, and many of them have been in the United States. We've seen many of the stories of burnout, anguish, frustration with people leaving the healthcare workforce. And as many of you know, I'm a nurse, and we went into this pandemic estimating 6 million nurse shortage over the next decade or so. In fact, now that has been doubled. But I think our failure to consider the healthcare workforce as people has led to many of these challenges. Many of the descriptions, particularly in global health, focus on heroism, sacrifice, and maybe that's not a model that's fit for purpose either. And we know across the world that in particular mental health issues are a major issue, and these issues are acute in high income countries, but amplified so much more in low and middle income. Healthcare professional ratio to population is much lower. Losing one physician in sub-Saharan Africa can be really catastrophic. And then the other thing that we also have to think about, particularly in the context of women's work, much of the work in healthcare, particularly in low and middle income countries, is unpaid, either just through gender-based roles, but also through the lack of government support. And if we're being provocative and critical, sometimes I've often thought the community health worker agenda, beyond the importance of engagement with the communities, has in a way created a low or no pay cadre of healthcare workers instead of working towards the professionalization of healthcare. So these are some of the things that I think that we need to think about in terms of the healthcare workforce. And what I worry about over the next few years is the decimation of healthcare workforce in high income countries is going to lead to an exacerbation of the brain drain that we've seen across many decades. But I think the onslaught of COVID-19 across the world is going to amplify many of those issues. So I think workforce is such an integral part of this conversation. And I would also think that we need to rethink about, particularly in the context of non-communicable diseases, hypertension, etc. And many of the aspects, the risk factors that contribute to non-communicable diseases are also related to work, not just the work of healthcare professionals, but work across society. So we know that, shift work, lack of sleep, all of those things contribute to metabolic disorders. So I think we've really identified over this excellent panel and stellar speakers that we have to think and do things differently. I was really, a picture says 1,000 words, and Agnes's images, particularly of the expenditure in the United States, was very, very chastening and startling. So I wanted to start off with a question to the panel, which is going to draw on Adnan's affirmation that public health and health is fundamentally political. And let's just put to the panel that many of the drivers of NCDs, particularly, inactivity, diet, the stresses of life, are actually maybe driven by the private sector and business. And even though there's some pockets of global health, in particular tobacco control and maybe saturated fats where we focus on industry, have we put enough attention on looking at the intersection of business and health, particularly in the context of non-communicable diseases? So I'll just invite any of the panelists to respond to that question.
Well, maybe, yeah, go ahead.
Agnes, you go ahead. No, you go ahead, Agnes.
No, I mean, definitively not enough. That's, I think the answer is clear. But what I wanted to say is in fact, it's beyond business, is the incredible experiment that our societies have been going through for the past 70 years in our new mode of nutrition, right? Is the food system we've been building in the 20th century, which is so different from the food system that we have had for thousands of years. And that civilization that is relying on processed food that has been produced with pesticides and with large quantities of water. And we see now that we are at the stage where our food system, which is driving the tsunami of NCDs, is also contributing to the environmental degradation and the models of husbandry and the animal life that we are supporting for our food system. All of this is also contributing to infectious disease. So it is obviously driven by an entire commercial system that is oriented towards profit. And the question is how do we incorporate the externalities, what the cost of this food system to all of us, to us in the future. This cost is not integrated in the price of the food we buy. And we are paying for it in terms of now biodiversity loss, antibiotic, microbial resistance, and the tsunami of NCDs. But it's civilizational, right? It's the civilization, it's the system. So it is beyond businesses. it's the choices we are making on how we feed ourselves.
Thank you, Agnes. Adnan?
Yes, thank you very much for that question, Trish. And I think one of our attendees has also raised this in the chat. And I believe that the public sector industry complex is worthy of tremendous attention for the next decade, because the line is blurring between the public sector and the private sector, for the reasons that many in the industry are now sponsoring and supporting initiatives in the public sector. Many public ministries, including in high, low, and middle income countries, are now accepting funding from the private sector. United Nations agencies, some of whom I work with, have accepted money from alcohol, for example, and are involved in promoting things around drinking and driving. There are some inherent conflicts of interest that are being subsumed within such relationships that I think need to be exposed. So I think that our neat and tidy diagrams of these sectors separately are no longer viable. The second point is that I think we really have to push the boundary here. I think when you have global health policies at the level of UN and WHO, national health policies at the level of nation states being opened up to influence by industry, then I think you have the possibility of mitigating pro-health, pro-public health policies being reduced in the favor of what Agnes has called the profit motive. And I think this is something that really needs to be looked at very carefully. I think we have to be stronger. I think we have to be more transparent in these. I do not think there is an ideal model. And in this particular instance, for those of us who are coming from the developing world, I think you actually have a better chance at solving this than those of us operating in high-income countries where these are very old and sometimes hidden relationships. So I think those two are critical for our future.
Thanks, Adnan. And I just want to remind, oh, please, Laura.
No, I just want to mention that I also think that we need to emphasize more and more, and we have not done, I think, a great job in terms of putting into the light the health, the social determinants of health. Because if we look at that the outcomes in health are due to the social determinants of health, then we would know who is intervening in all those in the social determinants of health. And very early in the time, we would know that transportation and you know, employment and education, the way we build our cities, all of that has an impact in our health. So I think that we have to have a better, you know, communication strategy in order to make sure that we are working to, besides, you know, the health professions, all of the industry, the private, the government, but beyond that even, we need to be all working together towards really attacking the social determinants of health, where it lies everything that we are talking right now. This is a consequence of not looking at health and well-being from a social determinants perspective, and who's causing us to be healthy or sick in the very first place, and bring all the actors, you know, to the table.
Can I just put to the panel, do you think, sorry, Abigail?
Yeah, I just wanted to comment to say that as much as we've heard how much the business community is doing about health, but I think for low-income countries, it may not be the same. So I think from this end, maybe we need to strengthen a multi-sectoral approach to addressing these issues. We can not only rely on the Department of Health to address, because we have evidence from the north, that a lot of people are being involved in order to address these issues. So even in terms of advocacy, it should not just be to the Department of Health, but I think to all these other sectors that are, you know, involved. For example, you talked about physical activity. You know, if you are getting kids, I think Department of Education is well positioned for that, because this is where most of the kids spend their time. Thank you. That was just an example.
Thanks so much, Abigail. And I was just going to put to the panel that I don't think we have enough of a conversation that disease is actually big business and fuels a lot of spending, and there's a lot of kind of investment in illness. So I'm just really conscious of the time. This time has gone really quickly, and we've got about 15 minutes left. Many of the questions in the chat relate to our focus on increasing the intersection and the discussion and the debate between NCDs and communicable diseases. And one of our participants has sort of looked at, why did HIV get such a huge global response in compared to other more, I guess, other conditions such as tuberculosis and malaria. And I think they're very important observations. And for us trying to work in global health, give us some information to move forward. But just, I thought what might be really useful to kind of conclude the panel and hopefully summarize some of the responses to the questions that we've had in the Q&A and chat. I might just go through our speakers again and ask them just to leave us with a concluding thought. And in particular, for our participants, how they can move forward and increase their ability to advocate and engage. We're just going to have like a minute each. Abigail, can I start with you? Oh, Laura, sorry. Laura, can I start with you and then Abigail?
Absolutely. And first of all, I have enjoyed so much and learned so much during this session. And I really like maybe to end by something that actually Adnan said in terms of we need a major disruption. I really love that phrase because I think that we really do. And when we talk about, there's so many challenges and where do we start? My suggestion or my own, thinking is that we should start with at least two things, and that's the workforce and the data modernization. Because if we don't have the personnel that we're going to be, tackling all these challenges, then we don't have anything. And if we don't have the data that can show us where are the gaps and where are the advancements in, in everything that we do, then we are just driving a car without the, the driver there. So I think that if we are struggling, which we are in finance, at least we need to really move the needle and major disruptions in the way we are training the people in terms of the workforce and the way we are actually coming to the workforce right now in uploading all other, their skills and coming up with different models in order to really keep on with health, well-being, and of course, care. So that would be my ending points.
Thank you so much, Laura. Abigail?
Thank you so much, Pat. For me, it's policies and the health workforce. If we are going to make any progress, I think we need to look at our policies that we have and see how best we can revive our public health systems in Africa. Sometimes we do have policies that do not augur with what is on the ground, or maybe we have been influenced to develop those kind of policies. But what are the policies that are going to transform our public health system in low and middle income countries? Issue of workforce is complex, and I think it requires a lot of advocacy. We trained, following the HIV pandemic, we trained a lot of health workers. They are there, but they are not being absorbed in the system. We are being told your wage bill is too high. How do we resonate with the current situation? Now COVID has reversed the situation. We could be heading back to where we were before HIV. Thank you.
Thank you so much, Abigail. And I'm so glad that your internet sustained. Agnes.
Yeah, no, I really wanted to respond to this question on financing. We hear very often that the burden of NCDs is extremely high globally, and that funding goes mostly to infectious disease. And it's not true. I think it comes mostly for confusion of what we call global spending. Global spending is global, and global spending, as I said, is 80% in high-income countries and 42% in the US, which most of the global spending on health today goes to NCDs. So it's only external aid going to low-income countries that is geared towards infectious disease. And that's a very small amount. It's 0.2% of global health spending. But again, I think there's a lot of time that is spent on trying to do this kind of accounting for advocacy. And I'm not sure it is the right way to go. And this is where I agree very much with the view that we need to address this differently, because we need to look at where we are globally in 2022 after COVID, or during the COVID pandemic, because we're still in that pandemic. And we are facing a tsunami of NCDs, but we're facing a tsunami of environmental threats and their consequences. That is drought, famine, migration, lives that are disrupted, infectious disease, which we may not know yet, that may, emergent diseases. So the question is much more about what it takes to change the fundamentals that is driving good health, the fundamentals of how we eat, how we, what is it that we consume, what is our behavior, and how these behaviors threaten both our environment and our health. And that, I think, is a complete rethinking of the framing. It's not about putting diseases in a box, which increasingly doesn't make sense on a biological basis, but it also doesn't make sense on an epidemiological perspective, because it's all driven by our behaviors, as consumers and our behaviors as citizens. So this is where also I agree that it's both a private sector issue in the sense of every one of us as consumers. We can influence the private sector. We just stop buying, right? That's the best way to influence the private sector. Just stop buying the products that are harmful to health, harmful to the environment. And the public sector, it's let's be the kind of citizens that actually drives better policies. So that's what I would suggest as a perspective.
Well, thanks so much, Agnes. And just before we move to Adnan, there was a comment in the chat about medical schools being disruptive, and I just think from CUGH, many of us educating health professionals have a really important role. Many of us people very early in their career get challenged in medical and nursing and allied health training to think about, I'm only looking after the heart, or I'm only, and that's why we also need to move towards an intersection between acute care and public health, as we've seen in COVID, because again, they're arbitrary distinctions, which Agnes has identified as really just the reflections of the previous decades and not necessarily the optimal model. So Adnan?
Thank you very much. And I think my colleagues have really said fantastic statement. So maybe I'll just use my minute to reflect on what I perceive may be an issue for introspection as well, which is I don't want low and middle income countries waiting for solutions to come from high income countries or from the United Nations or from the World Health Organization or from the World Bank. I think that it is in the power of people within those countries to exert their agency to begin to advocate for what they need, to influence the policies that they need developed for their health concerns. And very importantly, as Agnes demonstrated, that the lack of domestic financing for these really is important, that we cannot ignore, that no matter how small, that is extremely significant, and that demonstrates the political priority that governments and the public are placing on reducing NCDs if there is in fact a line item budget, if there's financing towards it, no matter how small. It is very, very significant. And so I think that sometimes we wait for solutions to come from other places. And my plea is that we should not do that. We shouldn't do that in the space of financing and in terms of policy, but we also shouldn't do that in the space of developing workforce. Some of the best models that I am studying in terms of health workforce development actually come from Africa and Asia. And it is time that the United States and United Kingdoms and Australia learn from those models. So I believe in this bilateral flow in what is sometimes termed reverse innovation, but I believe it's actually bilateral innovation. And I would plead that this is the space that we need that more than ever. Thank you.
Well, thank you so much. And I think this has been a very stimulating, provocative, and panel that has really given me a huge amount of food for thought. I think we've heard some very important messages that in order to address the tsunami of NCDs, we maybe have to approach how we conceptualize not only the categorization and management and assessment of these conditions more holistically. We've heard a lot about the importance of interprofessional care, and we've also heard a lot about how we can advance through our own individual responsibility. So I think as we, I would like to think, come to the end of the pandemic, I think this is a stark reminder that it's coming to the end in many high-income countries. The rates of vaccination in many parts of the world are still very, very low, and we probably still face a very uncertain future. But what has been clear from this panel is what we've done before is not fit for purpose moving forward. So it leaves me just to thank my exceptional colleagues. I'd also like to thank CUGH for fostering these important conversations. My sincere thanks to Keith, Dalal, and Jenna. And I wish everybody the very best, and also really commend many of you here today who have worked incredibly hard at one of the most challenging times in history. And I think that's a strong signal that organizations such as CUGH are just critically important for moving forward, addressing challenges, and hoping for a better world, and not just hoping, but doing things to make that happen. So thank you so much, everybody, and have a wonderful evening, morning, afternoon, wherever you are in the world.
Thank you.
Thank you all.